Hello and welcome to the next episode of the Science of Teaching Movement with myself, Lincoln Blandford. Now, in this episode, this is another opportunity to talk to Mark Comerford, and as part of the celebration of 30 years of Kinetic Control, we're having a multiple series of chats with Mark. So in this particular episode, Mark gives us insights in terms of putting the bio back into the biopsychosocial model, the relevance of EMG literature in respect to the timing of muscles and also their relative contributions, the relevance of this in terms of those who are scared of pain, the some of the previous literature that's used cognitive control type testing to also consider and reduce recurrence. We touch on fatigue and its comparability with pain, so the influence on muscle synergists, and also if we know we're going to recover from fatigue and if we know we're going to recover from pain, it seems to have a bit of an impact with respect to then how we move. We also touch on those who have expressed concerns about using a movement approach with respect to both acute presentations and also profiling risk. So some nice ideas about how we can mitigate those particular concerns. Can we use also movement to inform on coachability of athletes? So again, another nice component of the conversation explored there. With respect to specific populations, Mark discusses dancers and the surprise in discovering so many of these dancers have restrictions through the anterior hip, which he then associates with the amount of high kick movements that are performed, which then allows us to talk about other sports in which kicking is key. We then move into running and consideration of front side mechanics, and could this have a relationship with hip impingement? We mentioned psoas as a posterior tilt muscle, which again would be in conflict with a lot of the literature out there. So a nice point of insight, perhaps, and also how we can use a muscle classification model to navigate this thing called motor abundance. When there's many muscles that can do the same thing, let's say, how do we make a decision about what we might try to target? We then end up with further discussions, including how then thigh muscle injury could be associated with the pelvis. So as ever, it's fascinating talking to Mark and getting insights from this wealth of experience.
Yeah, and it's sort of disappointing in one way is that, yeah, just because someone's got pain that's been hanging around for a little while, we almost stop thinking about the neurophysiology of what's going on there. And we have really clear evidence that we can change that neurophysiology. We can change the recruitment patterns, yeah, with all of the things that we do, and particularly in kinetic control. So I think there's going to be a bit of a future there. Is that there's going to be a bit of realization that the pendulum keeps swinging from the bio to the psychological, and because there's been such good research on the psychological and social sort of stuff for the worst of the worst, then that's developed a lot of social media attention. It's developed a lot of attention in the academic literature too. But sort of the bio part, which is still there and hasn't changed, and is still there are real neurophysiological changes associated with that, has just sort of been left behind. So, and I think it's going to catch up. I think there's going to be a change in the future where we're going to start addressing that again, because there's a lot of research that's looking at that, and it's just sort of been it's just been left behind because of high quality research in the other area. It's sort of stuff that just keeps getting reinforced from the work on the EMG studies showing that we have timing changes. So the studies that show this the EMG stuff that goes right back to Hodges stuff, early stuff, where we get feed forward changes, so timing delays, we get increased recruitment of the mobilizers, so Henry Sow, Hodges, that sort of stuff. And then other people have just been reinforcing that as we go along. So inhibition of these deep muscles, local and global stabilizer muscles, has been really well established. And some of Lorimer Moseley's stuff even showed that if you make people scared of pain, you get the same changes. So when you're confident that the pain it's not going to be there, you can recover again. But so the fear of pain is significant as well. So, but those changes occur within minutes of you getting pain. But they recover quickly if the pain's not there for long. And if the pain's there for long enough, then what we also see is that the pain can go away, but some of those neurophysiological changes don't recover, and they can the failure to recover some of the recruitment neurophysiology even when the pain goes away has been linked to recurrence. There's a strong statistical link. And one of in the first study that looked at that was Julie Hyde's stuff, where they showed that, in people with first episode back pain, if you did good cognitive retraining of these deep stabilizer muscles, the pain got better in the same range in the same time as people who didn't do that work. Okay. But the big difference is that there was a huge difference, decrease from 80% recurrence to 30% recurrence, just because they did that cognitive retraining. And I think that's one of the things that we see is that what we're seeing nowadays, the cognitive retraining may not need to be as specific as what all that early research showed. And so I think we're seeing things like, Peter O'Sullivan's cognitive functional therapy sort of stuff. So long as there's a cognitive effort to change the way we move, we are going to make changes in the central nervous system. But understanding the neurophysiology behind it can give us better strategies to do that. And so we're seeing sort of the whole concept of movement mentoring process, and the movement science practitioner courses to do that too. We're looking at people as changing the way that they coordinate muscles, and that changes the physiology of these deep muscles as well. There's lots of other approaches out there that are just trying to look at sort of change the way your alignment, changing the sequencing of muscles sometimes. What I think we do is we have a clinical reasoning framework behind those decisions we make. And we make that clinical reasoning framework that Kinetic Control puts in is very much based on the research on the physiology, the neurophysiology of what muscles do when they're not having to deal with pain, and how the central nervous system changes the recruitment of them when there is the presence of pain, and how some of those changes are persistent when the pain goes away and then leads into recurrence. So one of the things that we have is that the foundation of the Kinetic Control courses is built around looking at that neurophysiology, and the clinical reasoning framework process we've got is built around developing an assessment system of looking for the loss movement choices, of which is basically coordination and control of sight and direction impairments, and then also looking at the recruitment efficiency of the muscle synergists, the local stabilizer, global stabilizers, global mobilizers, how they work together in functional activities. And so in reality, sort of we've got this two-step process which has been right around from the beginning of Kinetic Control, which also underpins the performance matrix. Sort of is the sight and direction control component, and trying to do an evaluation of the loss movement choices that the patterns that we can develop, that we have an assessment framework and benchmarks for, and then retraining that. So the matrix and Kinetic Control are built around that framework, and that's also looking at within the Kinetic Control framework. We put the clinical reasoning based on the sight and directions of movements that are painful, and how can we control them, and can we change the pain mechanisms. In the matrix, we're looking at sight and direction impairments in multi-joint patterns of movement, so functionally orientated patterns of movement, where we can then look at those impairments that contribute or are related to pain in people who've got pain. If we can identify them in people who don't have pain, maybe if we can do something about finding that, assessing it, identifying it, and retraining it, we might be able to decrease the risk of developing pain in functional movement type activities in sport or other occupational activities. And so in the Kinetic Control framework, we're using the sight and direction to manage the current mechanism, the current painful provocation activities, and then the synergist retraining to deal with elements of recurrence, because that's where the support is. But in the movement science practitioner, the whole idea of trying to make people do FUPS activities and make the stabilizers a bit more efficient in those activities that are non-fatiguing, which is what ideally that they're biomechanically advantaged for, is a good thing. And so that framework of sight and direction, assessment of loss movement choices, then retraining that, and then looking at the quality of movement, and then looking at the efficiency of synergists as well, is sort of those two frameworks in the Kinetic Control framework. But they also have parts that cross over into the matrix, which is looking at risk analysis, and the movement science practitioner, which is looking at movement efficiency, really. Yeah.
I mean, I always say they're all written in the same code. It's just there's different reasons you're going to choose what you're going to use, so that they're for different outcomes, but they're all written in this sort of similar appreciation of in-segmental motions. And I'm using a biomechanics interpretation of segments here, but how those segments as part of a bigger picture, but also how their muscles coordinate as a part of that picture, and then being able to sort of trying to interpret one from the other, how people move, and then inferring that on maybe what coordination's gone in the muscles. Mark, so a question then. So your perspectives on alterations in muscle synergies in the presence of fatigue. So acute fatigue. You see literature showing that in the presence of acute fatigue, you're going to get change in the relative contribution of different structures. How in pain we get something similar?
Yep.
Are those processes comparable? Are we talking about something very different here? So is there a relationship?
I think they're very comparable. And the thing is, if the pain is minor and goes away quickly, then we recover automatically, almost a bit like fatigue. So most people with fatigue, we get these changes that occur, but they're not persistent because we recover from fatigue, and we can be, and also from a central nervous system psychology point of view, if you're fatigued, you know you're going to recover from fatigue, so you don't get scared about it. You don't get anxious about, am I going to recover? If we've got pain and it's something relatively minor, and you think about it, you analyze it, you self-analyze it, you think, no, this is minor, okay, and that's a lot of sort of the NOI stuff. That's a lot of the Butler, Mosey sort of stuff too. That if the perceived threat is minimal, we don't worry about it too much. We start moving normally. We don't seem to get such a strong central nervous system response. And as soon as the pain decreases, we proportionally recover the recruitment. And so what we do see is that in induced pain studies, when people are given pain, and I've actually been a subject in some of these, is that as soon as you're confident the pain it's not going to come back, you recover your normal physiology if you started off with normal physiology. Okay, and so I think if the pain can go away quickly because it's a relatively minor injury, you're confident of that as well, you're not scared that it's not going to go away, then it is very comparable to fatigue. The fatigue will go away, you recover your normal physiology, and you're confident that's going to happen. If you've got a minor injury, the pain's not severe, you get certainly inhibition because of the pain, but if you're not worried about it, you keep functioning normally. You don't make it change your behaviors of how you're functioning with that pain. And when the pain goes away, most people would tend to recover their physiology pretty normally as well. And the induced pain studies show us that. There were a group of patients who they gave them experimental pain and were expecting the pain to recover very, very quickly, and they didn't. And so that was almost going to be a sort of a curveball in the ethics. And so they followed them up, and then basically what happened is that they did recover, but they started asking that because they did recover. The question was why did that small group of people, I think there were 4 or 5 of them, if I can remember correctly, that didn't recover immediately after the pain was in the same session, and when they sort of reassessed them a short time and a couple of days later or a week later, a week or so later, they had recovered because they didn't have pathology of pain to start with. But then the question was, well, what might make these people different? Why did they not recover? And that's when they started thinking about there might be psychological reasons, and then and then I think that's when they started looking at, well, did let's put some psychological tests in, and it seems to be that those people scored a bit higher for things like kinesiophobia, fear avoidance strategies, fear avoidance patterns. So people who are a bit more anxious about is it going to get better are the people who may not recover, because your psychology affects this as well. So the things that we know might influence the changes in the neurophysiology are pain itself, okay, but also fatigue does the same thing, but we recover, and then anxiety or being anxious about is it going to recover. So if you perceive that the pain may not be, even if you perceive the pain might be severe, but you think, have I done something nasty? Is it not going to get better? You internally focus on that too much, and the central nervous system stays in protection mode. So I think a lot of these neurophysiological changes, we can think of them as being a protection mode generated from the central nervous system, and you need it if you've got pain, you need it if you've got fatigued, and you'll maintain it longer than normal if you're scared about it, or if you're anxious about it because you overprotect. And that's what we do see in the psychology of chronic pain patients, is that hypervigilance, and excessive focusing on, the intensity of the pain, the quality of the pain, that sort of stuff, the little things that make it worse, rather than focusing on the things that you can do in the presence of it.
The I guess the concern with some of our testing then for some people is this fear of movement story that, oh, well, you're saying don't move this and you should move that. Oh, well, if they've got fear of movement, you're only making it worse. So what's a good sort of response to that sort of critique, I guess?
Okay, well, again, I think that and my personal experience with patients who've got that sort of, every time someone makes me move or I hurt, I get worse. And so, I've been to lots of therapists, and everyone's tried to make me stronger. Everyone's tried to make me move more. Okay, and all it does is make me worse. I'm thinking, okay, this person is anxious about me. Now another therapist going to assess them and make them do that sort of stuff. And so my way of thinking of this is let's not give them the feeling that I'm going to assess them moving, looking at how making them make the muscles where they work, testing them, that sort of stuff. So I basically use a story saying, oh, well, I don't want you to move. I'm not going to make you move more where you hurt the most. Okay, we're going to do a couple of things different. I want you to protect it. If you feel like you need to protect, I want you to protect it. So don't move where you hurt, but I'm going to make you move somewhere else, and seeing how well you can tolerate moving somewhere else while you don't move where you hurt. And then that effectively is exactly what we do as part of our sight and direction control work. We teach people to cognitively not move where they hurt. Okay, but don't tell them. Don't let them know, don't point out the fact that they've got to activate muscles where to stop them moving where they hurt. That they're naturally protecting it anyway. And so the idea is that don't move where you hurt while you move somewhere else. Move at the next joint, move at joints two joints away, and let's see what you can tolerate without irritating where your pain is. And what they successfully start to do is they successfully start to activate muscles to stop them moving where they hurt the most while they move at an adjacent joint. But and then the idea is that once they're happy that this is not making them worse, then it might not be the closest joint. So, for example, if it's back pain, I might make them move the hip, or make them move the thoracic spine or the shoulder. But otherwise, it could just be little knee bends. Don't be the back while you bend the knee, do little quarter squats. It could be that don't let your back move while you lift your arm up to the side or shrug the shoulder up and down. Simple things like that. But if they can do that without making their back pain worse, while they are cognitively preventing or controlling the back, they're actually activating muscles there. And then you don't scare them by telling them that to start with. They're already fearful of making muscles work where they hurt. But then once they're doing that and they're confident that this is okay, then we can say, well, you're actually activating muscles. You're actually using muscles to stop you moving there, but it's low force. So what we're now happy with is we can talk to them. So long as you're not using high force contractions, you're not using large range movements, you're not using high force contractions in the area where you hurt, you can do low force contractions, okay? And breathing does that too. So you're going to activate muscle, but we're going to work out what sort of muscle activation you can do. And so long as it's cognitive activation while they're doing that, we start to see them changing the central nervous system recruitment patterns. They start to activate these deep local stabilizers, start to activate the global stabilizers to control the movement, and then they do the bracing strategies around it. So that's effectively, and again, part of the cognitive retraining we're doing. It's a little less specific. Okay, it's not so specifically saying you've got to tighten this muscle up or activate this muscle, or pull in your tummy or tighten this muscle here or sort of whatever. We just say in the most comfortable way you can. Don't move there while we move somewhere else, and you only have to move a little bit until you're happy that this is okay. And so that's partly how we can sort of get an in for people who are have a bit of the fear avoidance, a bit anxious about the movements. We don't have to tell them what we're doing to start with. Let them experience the change. Let them experience what they can tolerate in terms of cognitive movement retraining, and then we can actually then fill them in on the details a bit later on once they're again happy, because once they know that they can cope with this exercise, this movement pattern that we're training them to do, the threat level goes down, because the brain said this is not a threatening movement to me because it's not making me worse when I do this, and so the threat level goes down. So they start to change some of that fear. They're still fearful of doing heavy loaded work. The strong contractions. They're still fearful of doing stretches. They're still fearful of doing large range movements. But we now got them starting to change, do something that's positive, And it's based on the principles of what we've already been teaching throughout without our kinetic control framework, our principles and strategies.
If we just then touch on matrix on this, if we're not dealing with somebody who has presentation of pain history or pain presence, but we then do some testing, we're going, oh, okay, so can you prevent your knee crossing in the midline? Can you stop the side bend going on? And we're saying, oh, okay, we have to score it as no. Now sort of identifying to them that they've got all these sort of movement patterns that people believe are associated with an ACL.
Yeah, okay. Well, number one, tell them that they've been playing this sport or doing this activity with the same pattern for a long time. So you've been living with it and it's not a problem so far. Okay. So we want to take that thread out. So we're looking at risk factors that are inherent in what you've already been doing for a long time and you're coping with. Okay. And what we want to do is see if we can decrease that those risk factors so that you can keep performing those activities, but we can then modify some of those risk factors, and then that will change the stresses on tissues that are part of that we might consider and if someone already has the problem, we'd be doing that as part of their rehab anyway. But if we see these movement control changes, these lost choices that we can identify in functionally rated activities, by teaching people to control them, okay, it does two things that the research in particularly tells us. Number one, it increases variability, and everyone agrees variability is a good thing. Having more options to do things, having more choices, and what we all agree is that not every pattern of variability is biomechanically advantageous. And so we've got lots of variability, but when we're trying to look at these risk factors, we are trying to recover more advantageous variability. Okay, so it's biomechanically more advantageous to not have your knee drift in over your foot and create valgus on the knee. It's more biomechanically more advantageous that when you do a single leg landing, you don't have side bending or side bending of the trunk or side shift of the pelvis, because those factors contribute to back pain, hip pain, knee pain. And so if we can sort of find, so part of what we're looking for is, and this links into some of the research that we did with Bart Dinnigan, is that paper that we're enrolled in, looking at some of the biomechanical risk factors of how you might single leg land and look at that, but then looking at sort of some of the sight and direction control impairments that go with that, the ones that you don't have that link to those that have relevance to the biomechanical risk. Okay, we can then build some of that in. So part of the dealing with the biomechanical risk is looking at your coaching options. So getting people to practice their movements in certain ways, but giving them the building blocks by doing sight and direction control work, and recovering some of those lost choices that they don't have, recovering the variability that is biomechanically advantageous, is a win-win.
So that idea again, that being able to sort of control specific segments at will, would seem to be key to having coachability, as it were. Yeah. That if people are going to start changing how you move, well, do you have that ability to do that at the segment level? So if you want to take it down to the lowest kinematic degrees of freedom at the segment, you're going to struggle to get any lower in terms of a kinematic degree of freedom than that.
And the number of times I've heard from coaches, this person's got this problem, but they know they've got the problem. We're trying to work on changing their technique, but they're not successful at changing their technique. And for me, that's where some of these inherent movement control, coordination components are holding them back from the coaches developing technique correction in their running action, in their tennis serve, in their golf swing, in their throwing action. So all of these things that where coaches in particular say there's a technique fault I'm trying to address, but this player or this competitor is struggling to change the technique with my coaching skills. Often behind it, there's movement control and coordination issues that are limiting that. Sometimes they don't need. Sometimes the technique is easy and they change those patterns just with technique work. But sometimes there's restrictions. Sometimes there's movement control and coordination impairments that the building blocks are that without those building blocks, the improving technique or changing some of those performance markers just doesn't quite make it.
I meant to ask you this the other day, but at this point now in 2025, what's your best perspective of where that coordination deficit is? What's the mechanism behind somebody not being able to pass a test of sight and direction?
Okay, so why do some people not have pain but have the sight and direction impairments? Okay,
Yeah.
Right. Okay, so one of the things that we see is that if we just go back, pain changes the neurophysiology of how we activate muscles. Yes, so we get inhibition of the stabilizers, we get increased central recruitment of the mobilizers. Okay, but then, so how can we explain then? Well, why might people who don't have pain, no history of pain, why might they change that? And I think the link behind that is habitual movements. Okay, so what happens is that people have habits, and those habits are, and this is a bit like posture. Okay, people change postural alignment because of habitual ways they move, and so some muscles lose extensibility because of the habitual movements we have. We either overuse them, overtrain them, or we don't stretch them. We use something else, and we move somewhere else. So short hamstrings are really common in people who don't have any pain. Okay, and why might they have that? Habits, training activities, postural changes, some things of how they've grown through their adolescent growth spurts. There are a lot of possibilities. I've got tibiovarum, and I know I got that from running on cambered roads when I was a distance runner at school, in my adolescent growth spurt. So I've got structural changes that I used to have, knee valgus and excessive external tibial rotation, but I've corrected that. But I still have structural tibiovarum. Okay, but my movement's recovered. So movement habits, trained activities, the ways you sit, the way you stand, some activities that you do, which we develop myofascial and articular restrictions in certain parts of the body. We all develop that, and we compensate for that in other parts of the body. And so I think that's how it starts. You don't have to have pain to get loss of joint mobility in some place that you compensate adequately in other places. But where you compensate doesn't necessarily hurt. But then over time, you might lose the ability to coordinate, recover some of those patterns. So that's a little bit about sort of, some of the loss of variability that we've got. So the more variability we've got, and so I think it's habitual movement. So I think it's postural changes. I think it's trained activities that we develop these changes in the absence of getting pain. But if we keep them and we overload them, either with excessive load or with repetitive movement, they've got a real chance of turning into something pathological over time. And if we can identify them before that happens, we can decrease that risk of something turning into a pathological pattern or problem.
So low variability in behavior. So some sort of consistent, So then that can then start to change how segments can be coordinated. We can identify that through a cognitive test, which is
the cognitive test identifies the ones that they've lost, and we can do something about that.
Yeah. Oh well, we can put it quite straightforwardly in that case then.
I think so, yeah. And I work with a lot of people who are in the dance world and circus world. So and there are hypermobile people out there who have restrictions. The most common see, I think, in teenage classical dancers are hip flexors that are short as hell. And you think, why would a classical dancer have short hip flexors? But it's the most common finding I find in them. And because basically they do so much hip flexion work, and they've got hamstring flexibility from hell. So they've got that range, and those and like I see rectum sartorius being super short in these people. Okay, but they don't. But what happens when they try to extend the leg? They've got tons of spinal extension, so they've got all the movement, but it becomes a risk factor for lumbar extension, and it becomes a risk factor for hip flexion impingements. And it's the single most common. But the thing is, you would not expect an elite classical dancer who's working full time or looking at a profession in dance to have short hip flexors. But it's the single most common thing I find in classical dancers, even when they don't have pain. So I've got 2 dance schools that send me every dancer that comes into their system for reviewing, just looking at patterns of what's going on. And I would say that probably 60% of all the classical dancers that I see for the first time have short hip flexors, 2 joint hip flexors.
So the natural evolution from that story would be then our kicking athletes.
Yes. Same thing. Okay. And the thing is, if they've got if they're reasonably flexible, then the extension that they need to drive through and to run and to sprint, loads their back up. So it's not uncommon then to see them starting to develop some lumbar issues over time, because their lumbar spine and anterior tilt is their compensation for their lack of their hip flexors that are part of the problem. But again, and it's not something that happens every time they move, but it just changes the balance of forces, and it becomes easier to use anterior tilt of the pelvis to compensate for that. And it's easier to actually flex the hip with those big muscles for postural control activities rather than just the kicking. So we see when we also assess the efficiency, the recruitment efficiency through range of those the deep hip flexors, iliacus pectineus, they're inefficient, but they've got these big, powerful rectum sartorius. Okay. And then, not surprisingly, they start getting hip pain, groin pain, and they start getting back pain. And the thing is, I can pick this up in people. I can pick this up in these people, these dancers. I can pick it up in footballers when they've got no pain. And that's the time to start. That's the time to pick it up if we can, rather than put the fire out once the bushfire started. That's a bit of the principle behind what we do in the matrix. We're looking for those patterns that, okay, why do you have, a lost movement choice of excessive lumbar flexion, or why do you extension, or why do you have a lost movement choice of uncontrolled or excessive hip flexion? And then we go, okay, well, what might be contributing that? We can identify those background changes in the synergists.
Anterior pelvic tilt's becoming the dynamic knee valgus for hamstrings. So that's where we are at this point in 25. There's literature starting to show this, and there's also literature who are keen to change running, and they're achieving changing running by giving everybody more posterior tilt, or they're getting more front thigh drive, so more sort of front side mechanics.
Yeah.
There's a bit of a risk here with front side mechanics that if people can't control an anterior pelvic tilt, we're going to get some sort of impingement type outcomes.
And then the question then is, okay, what are you going to control the anterior pelvic tilt with? You've got a lot of choices. You've got your hamstrings, you've got your adductor magnus, you've got your glutes, you've got your abdominals, and you've got your psoas. Okay, so they're all the muscles that you can use to produce posterior pelvic tilt and control the anterior pelvic tilt. Okay, and then how do you make a decision about which is involved here? What do you need to build in? And I think what we've got is we've got ways now within the framework of looking at muscle recruitment efficiency for those muscles. So and so do we want more hamstrings at the expense of the glutes, or do you want more glutes at the expense of the hamstrings, or do you need a certain combination of balance? Do you need the glutes for the low threshold work? You need the hamstring to drive the sprint. Acceleration. So we can build those training programs in based on but we need to stop thinking. We need to think a little bit more detail about, so the posterior tilt, if that's our goal, how are we going to achieve that? We can do that with movement coordination exercises. So we can maintain the posterior tilt while we try to and prevent anterior tilt while we extend somewhere else, extend above or below. Okay, and control that anterior tilt. So there's a sight and direction component where we're not worried about which muscles control the anterior tilt. We're just controlling the tilt while we move somewhere else, challenging that ability. But then we can go down the path of, okay, if we want to really finish the job, which are the muscles that can control the anterior tilt? Which are the most posterior tilt muscles that are not doing that are not effective enough, that are not efficient enough, and not doing their share of this patterned movement?
The muscle classification model, I would see it as a way to give weighting to motor redundancy. So the abundance idea of you've got loads of different structures that can do the same sort of things. You can get to the same place by using different ways to do it. But how do you make a decision? How do you have a compass to guide where you're going to go? And the muscle classification model's a very nice way to do this, to give weighting to, well, motor redundancy, if it exists, okay, how do we make a decision about where we should push, which way we should direct motor redundancy? So it really helps with that.
It does. And especially if they've got pain, it tells us the movement we need to control, the one that hurts. Okay. If they don't have pain, then we're looking at, well, what are the performance advantages of controlling this one versus that one? And so that's what you're talking about with the posterior tilt. There might be a performance advantage for being able to control that anterior tilt, even if people don't have pain. So we still do the same thing. We can do the same tests.
Do you see any issue with, if we're going to give it more posterior tilt, is that any issue in terms of rec-fem type strains?
Well, potentially, but it's also, yeah, again, like it's a bit like how, do people get hamstring strains because, and then again, they're overusing one synergist more than the other, and one of the things that we see again, and this is what I see with the dancers with rec-fem, one of the things that we see in people with recurrent hamstring injuries is that their hamstrings have become their postural control muscle. So rather than using their glutes to control pelvic tilt when they're doing non-fatigue activities like standing and walking, okay, they're using the hamstring to do that. So the hamstrings are trained by the brain to stay on all the time and controlling pelvic tilt. Then when you're sprinting, they've got to go on hard and relax fast, on hard, relax fast. And if the brain's trained them to be the postural control muscle, then there's a conflict in the central nervous system saying, well, do I maintain activation to control the pelvis, or do I relax quickly? And then that's where the recurrent hamstrings things. I think the same happens with rectus femoris. If you've trained hip flexion as your dominant movement, and if your deep anterior stabilizers, deep hip flexors, iliacus and pectineus are not efficient, not doing their share, then your rec fem becomes your postural control muscle at the front of the pelvis, like the hamstrings at the back. And then they're doing the holding time. So when they have to do fast leg kicks up and down, or they've got to accelerate from flexion to extension, if those muscles that have to relax to allow you to extend quickly aren't doing their job, are doing the postural control work, then they don't relax quickly enough, and then we start to develop ourselves in rec fem strains and that sort of stuff. So the exact same analogy for the people who are on the flexion side, hip flexor side, is the same thing for the hamstring side. And I think that's where I think it's movement habits. People develop those habits of hamstrings becoming their postural control muscle because they've been a teenager standing around in a sway back posture for so long that they're not using their glutes. Yeah, because the glutes are disadvantaged because of the alignment, and the hamstrings become their dominant postural control hip extensor. And the same for the hip flexors in people.
So you've got a perfect storm then for the football player who needs to kick a lot, but also run a lot.
Yeah.
So you need to sprint, and then you need to kick.
And I think, and what I think with the kinetic control framework we've got is we can look for those, and people who don't have pain, we can look for those risk factors, So we might see this is a performance risk, but this might be a performance advantage or disadvantage we want to build in, or this might be an injury risk. We might want to we might see it's present, we want to take it out. But the whole idea then is that we can identify that, and the way that we start off with is identifying the site and direction of our lost movement choices. We've got structured tests for that. We've got benchmarks for that as well. We've got benchmarks for testing it individually. We've got benchmarks for testing it in the matrix in multi-joint movements. And then those things are ways that then gives us the framework of what the site and direction control problems might be. And then what we got to then is, okay, well, we can retrain that with cognitive movement retraining, number one. And then, but number two, okay, is we want to go back and looking at, well, how have we got there? Why has someone who's got no pain have this problem? It's easy to recognize that there's an habitual movement or habitual posture or a trained movement pattern behind it. And then we can start addressing changing those patterns, which muscles we want to look at, the recruitment efficiency of the synergists involved in those movement patterns that they've got, and then we can finish the job. And I think that's partly where the Dinnigan paper we looked at sort of biomechanical advantages and disadvantages, and look at the movement control things that go with that and how they link together. And I think Sarah Mottram's PhD, sort of added a bit more to this, is where we're looking at what Sarah did in particular was provide like a white paper type thing of supporting that these principles have real evidence. They've got real support behind them, and they link to the changes that we get. So and Sarah emphasised a lot more the scapular control as part of her PhD, but the principles that we developed in the whole kinetic control framework, which are underpinning the matrix, underpin the movement science practitioner courses too, are all built in there. And so looking at Sarah's PhD, where she looked at the evidence to support lost movement choices, the fact that we've got valid, good inter and intra-tester reliability in testing them, we've got benchmarks that we can identify. It's a battery of tests. There's no one test for one site and direction. We have to have a battery of tests because there's so many functional implications of that. And then looking also that that there are muscle synergies that go with this. So so Sarah's PhD sort of really put like the white paper type support behind providing that there's validation for this whole process, which was nice, which is great, you know, so a big stepping stone. And there's a lot of papers that came before that, you know. Warwick McNeil's paper that you did in 2015, looking at just number one, you know, using the term movement health for one of the first times. And then the one that Sarah and you did, again, looking at that, developing that a step further.
2020.
Yeah, 2020. Yeah. So those papers are looking at this whole idea of movement variability, loss movement choice. You know, and then, you know, looking at sort of that we can identify that, and we can also develop retraining strategies based on a clinical reasoning framework around that. But we can identify these, the fact that we can identify these things in people who don't have pain. You don't have to have pain first to develop these losses, the loss of variability. So, yeah, but once you've got pain, then the changes in the neurophysiology of how the nervous system activates muscles means it's harder to recover automatically. And if the brain perceives no threat or minimal threat, and you keep functioning normally and the pain goes away quickly, in the same way that fatigue, you recover automatically, pain you recover well. But the longer the pain is there, the more severe the injury, the more you worry about it, the more you're not sure about it. Yeah, the greater the likelihood that even with the pain, when the pain goes away, it might take longer, it might be time, but when the pain goes away, the way that we don't recover the physiology of the ideal or the patterns of recruitment that we had prior to that episode of pain or injury doesn't recover, and they're the things that we see in the literature predict, you know, recurrence, or when people have got recurrence, we see that in between episodes of pain they have not recovered this neurophysiology, even though they might be pain free. And recovering that neurophysiology is something that has been shown in some research to it's a bit hard. It's not very easy to do that. Yeah, prospective research. But Julie Hyes did that in her PhD and showed that if you can recover the neurophysiology, you decrease the incidence of you decrease the incidence of recurrence in these patterns.